I'm Dr. Craig Escude, the host of IDD Health Matters, a podcast where we talk about health, wellness, and health equity for people with intellectual and developmental disabilities. Hope you enjoy it.
Welcome to this episode of IDD Health Matters. I have with us here again for part two, basically.
Thank you for having me back.
Dr. Seth Keller. Thank you so much for being here. So after the last episode, we were talking about new things on the horizon related to dementia.
Absolutely.
And everybody wants to hear more about that.
Yes.
So tell us more about that.
Well, thank you, Craig. Thank you for giving me the opportunity. And it's been a while since we chatted. So glad to be back again. So basically, Alzheimer's disease, and there's many families who has someone that knows someone, directly that probably has Alzheimer's disease. It's tragic. It's such a terrible thing to lose oneself. And there really hasn't been any ability to halt, stop, change the reality that people are losing skills and abilities. And I treat Alzheimer's. I've been doing this for 30 years. And it's been, I say frustrating is an understatement for me as a practitioner, but for the families. But because the fact that people with Down syndrome, most of them are going to get it at some near future time, raises the stakes for them, obviously.
Sure.
Raises the stakes. And the knowledge about what causes Alzheimer's disease, there's been a huge increase in research in the last 15, 20 years. Money's been spent and it's really been a priority of the United States and other governments to do it. In fact, the United States, a number of years ago, created what's called the National Alzheimer's Project Act under President Obama, where the resources of the United States government and non-governmental entities, including the Alzheimer's Association, would come together to create a strategic plan of research, planning for support for this population. But because we in the developmental world, we know that we're not always included in these conversations.
Right.
We know that. So we had to advocate to be at the table of the conversations. So for years, we've been actually trying to press for people with Down syndrome and other forms of developmental disabilities to have a voice at the table at the national discussion about making sure that we are involved, our agency are involved about getting Alzheimer's research and all that. Well, what's been exciting is that there's two fronts that have been coming up in the last years about the research. Number one is to be able to test for certainty that the person actually does have Alzheimer's disease. And one of the difficulties about trying to diagnose Alzheimer's disease is it's all purely been a clinical diagnosis. I speak to the person, I talk to them, I do a scan of their brain, and I say, it looks like, I think it is Alzheimer's, I bet it's Alzheimer's, and they're provided that diagnosis of Alzheimer's, and they're provided whatever therapies there, which is not great, but it may not be Alzheimer's.
And we've talked about some of those, how those challenges are even amplified in people who don't use words to communicate. Many people with intellectual and developmental disabilities,
Absolutely.
We have to often look at maybe functional skills or changes in their activities of daily living and things that they do.
It's been a lot of inadequacies, little inaccuracies. So the way to make a diagnosis is what's called biomarkers. And the biomarker is the biological measurement of the disease or condition that you're looking to monitor or check on. The analogy would be, say, if I want to know that you have high blood pressure, I pump up the blood pressure cuff and I say, it's high.
It's high, there it is.
And that's a biomarker. Or the other one, say, if I want to know your cholesterol is high, it's a blood test.
So now we can do a blood test.
Yes. Or, what the disease, the pathology of Alzheimer's is beta amyloid protein buildup in the brain. And so the way to know if someone has Alzheimer's disease is to see either by spinal fluid, by what's called PET imaging, which can measure actually the beta amyloid in the brain, or by blood tests. So there's been a whole host of research in the last number of years going on to try to provide an accurate black and white diagnosis, yes or no, that the person really has it or does not have it. And because people with Down syndrome start accumulating beta amyloid because of the genetic propensity in their 20s, they definitely will have all the hallmarks of that accumulation. And even before they first describe they're having decline in symptomatology, they actually have all the makings of the beta amyloid protein, and they might even get a preclinical diagnosis of Alzheimer's before they even have Alzheimer's. So what the biomarkers are going to be doing in our country and around the world for people with Down syndrome and for other forms of Alzheimer's and neurotypical populations is to be able to have an accurate assessment of that they have it. Well, that's great, but what can you do about it?
So wait, is that available now?
It is available now, but our Centers of Medicaid Services don't pay for it. So if you want to get a biomarker, blood test, spinal fluid, you might get it if you pay out of cash, like thousands of dollars. And right now, it's mostly involved in research.
Most likely that will become available.
It's inevitable. I can't imagine not right. It's going to be an inevitability. So we have this up and coming reality that Down syndrome people will be able to know for certain. So really, so from that standpoint,
Anyone, really.
anybody.
Anybody.
Oh, anybody would be able to get tested based on, assurance and approval. Anyone could get this test and you'd be able to know. So we're going to get to that in the next number of years soon. This is not science fiction. This is something that's actually going to happen soon. And so we know the pathology is beta amyloid, and there's another protein called tau, and also what's called degeneration. So there's three aspects of the brain changes that lead to what's Alzheimer's disease. So there's a lot of research that really understands it. It's evolving. It's not all there.
So you said we're going to hopefully pretty soon be able to diagnose it pretty accurately.
Yes.
So that's the second part of this. So what's out there that we can do about it?
Get rid of the amyloid.
All right.
There you go. So getting rid of the amyloid.
It's that simple. That's all we have to do.
Get rid of the amyloid.
Yeah, let's just get that out of
right.
there.
Well, yeah. So, but that's really basically the nuts and bolts of basically the treatment is trying to get rid of the disease, the pathology that's building up in the brain, remove it, eliminate it, keep it from building up, and try to reduce the person's severity of Alzheimer's, keep them from getting Alzheimer's, let them live longer, all the mitigating factors. And that's right now going on in the pharmaceutical world. There are several different pharmaceutical companies that are investing billions of dollars in this form of research. And it's called anti-amyloid therapy. And what anti-amyloid, they're actually antibodies that actually are there given by infusion intravenous treatment every month to a person who's been identified by biomarker-proven Alzheimer's. They have to prove it. That's how the research is. They prove they got biomarker-proven Alzheimer's by these studies. They then give them these anti-amyloid special proteins to remove the beta amyloid from the brain, and then they follow them on MRI after MRI to see that they have reduction of beta amyloid, but also to follow them clinically to see what happened to their symptoms of dementia.
So first question, are they able to show a reduction in the amount of amyloid at this point with some of the treatments?
The gold standard, the first thing that these drugs must prove is just that. That's the first thing they must prove, that they remove amyloid from the brain.
Are we seeing some drugs that are doing that?
The first drug that came out 2 years ago, aducanumab, by Biogen Pharmaceuticals and Eisai, jointly they put this drug out. It was called Aduhelm. So Aduhelm was the first drug that came out a few years ago, and it was widely touted as it was approved by the FDA, and the only thing they proved was just that one statement of reduction of beta amyloid. So that was their bottom line. But what it really didn't prove is that it actually changed reality that they were going to get. Did it change your cognitive function?
And that was the second part I was going to ask you is, okay, so can we show that it reduces amyloid? And it sounds like there's at least one thing out there that can do that.
Absolutely.
The next thing is how does it impact a person's life?
Well, the other part about it was the side effects. So what happens is the side effects. So what happens is when you remove amyloid, you're almost like taking these things out of the brain, removing it and leaving, I wouldn't say holes, that's a little dramatic, but it increases the risk of small bleeding and swelling. So there's risks. So there are these risks. So one, it removes amyloid. A question, does it really help cognitive functioning? And then there's the risk to the person. And the studies that have always been done are normotypical people over age 65 who have either what's called mild cognitive impairment or early Alzheimer's. So whenever research study is done by whatever treatment for any condition, they have a very specific population that they're looking at. And the drug, and this is getting to this meeting that I had. So companies, pharmaceutical companies, do normotypical people. There's normal people that have these Alzheimer's symptoms, they have the beta amyloid, and they're the ones by black and white measures show these changes, the improvement of beta amyloid reduction. And then what has happened since Aducanumab came out, it was so controversial because it was $56,000 per year.
Wow.
And it had the risks to the bleeding and the swelling, and it had almost unclear benefit aside from beta amyloid. So it became a big to-do in the United States about whether or not insurance companies would even approve it when it's not really showing that work. So it became a major issue. And then in the Down syndrome world, because it wasn't tested on people with Down syndrome, we didn't really know for certain on how safe it would be, on how valuable it would be. So people were excluded in these studies with Down syndrome because they weren't part of the neurotypical population. And because the reality that people with Down syndrome were basically developing Alzheimer's every day and tragically progressing and dying, their house is on fire.
Sure.
And they can't wait. So basically the community, the advocacy community all gathered together when aducanumab came out, and they all came out together to put their voice to paper to our government to try to help ensure that there's equity to access to studies and research and quality.
And they were successful in that.
Partly so, but they weren't fully successful enough where future studies yet have done that. So what is now being done are companies still working together, including an organization that we work very close with, the National Task Group, and also worked with the AD&D Lumine IDSC. They're an organization that has been amazingly great about looking at this issue of Down syndrome and access and equitable care and research. And they basically are trying to find a way of these other drugs that are now, there's now 2 new other drugs besides the aducanumab. Another drug came out just last year. Another one, there's research that the FDA is going to approve maybe coming up this year. So a third drug, anti-amyloid IV monoclonal antibody, now showing that there is cognitive improvement. They're showing, but no people with Down syndrome have ever been studied or tested. So right now, we're trying to get our society, our government, our research arm, our advocacy all around trying to press that people with Down syndrome are able to have access to these treatments because their house is on fire and they can't wait.
That's another facet to the whole picture of health equity is research and the opportunity to participate in research studies and also to see if there are different effects in someone with an intellectual disability or a genetic condition as well too.
And there might be. I mean, and that's really where, as a doctor and a scientist, I'm an advocate. I'm a huge advocate. But what we don't really know is that people with Down syndrome who began developing beta amyloid in their 20s, they've had a lifelong developmental disabilities, is what would these drugs, these anti-amyloid drugs, really do to them? And and also there's an increased risk of this protein in their brain anyway, and also bleeding anyway. And also they got a lot of seizures, and then also when you're giving the treatment, you got to do MRIs again and again and again, and you have to assess them. You have to do cognitive assessments, like we talked about before, the EDSD and other ones. You got to test them. So you have to see someone with Down syndrome who's poorly verbal or nonverbal, and you're basically trying to assess them to know whether or not the treatment's effective. So, I mean, it's how do you know? So inherently within people with developmental disabilities and Down syndrome is when you're giving these products is how would that be if it's released? It's going to be open label, or people are going to get it anyway? Who's going to measure it? Who's going to get it? At what point should they even get it? Because of the fact that you can actually probably make a diagnosis of Alzheimer's using a biomarker a decade or so before they have symptoms, maybe that's when they should get it. Maybe they should really start getting these anti-amyloid medications when you can test them. They're all going to get it. So you can actually find out 10, 20 years before they have symptoms of Alzheimer's. Maybe that's when they start getting it, and that's maybe the best benefit, rather than waiting when they start showing signs of decline when they're already, might be late.
Are these newer drugs showing a similar side effect profiles and risks for bleeding?
Yes. Yeah.
So that's still, we're talking about using something preventative, but then there's a higher risk of bleeding. It's trying to figure out, okay, what's the risk to benefit ratio and all of these things.
And the challenge is in researchers, I mean, to me, it's really very difficult. I mean, I'm not on the side of research, even though I am a little bit, is how does one do that? And really, it's almost like, should it be compassionate use? Should you basically give these drugs for people that's dying? It's almost like if you're dying anyway from cancer, from Alzheimer's disease, then people might say, well, maybe you should offer them the treatments for compassionate use. They're going to die. And even though the black and white data on Down syndrome may not always be there like neurotypical population, it's similar pathology, maybe we need to be more open towards giving people these treatments when they're going to get it and die. So to me, it's fascinating. So last week, on Tuesday last week in Boston, I had this, it's called an In Conjunction With meeting, ICW meeting, which was alongside my American Academy of Neurology meeting. And around the table, we brought together 25 people, and also was virtually. And around the people that were around the table was Lumine, the organization that I mentioned, the national task group leaders like myself, Matt Janicki, our other colleagues. But we also had advocates, family advocates from the ARC was there. We had our good friend Steve Perlman, AD&D, was there. And we also had people that were Mass General that were there who had Down syndrome clinics. We also had people that were part of the Massachusetts Down Syndrome Congress were there. And we also had industry, Lilly Pharmaceuticals. So we had we had two medical science liaisons, and Lilly Pharmaceuticals is the one company that's working on these anti-amyloid drugs. And that was one company whose product that it was just came out with information a week or so ago, the third drug, that's now showing even better improvement. So these companies, so everyone is in this together. Everyone is in this together from a advocacy, science, research, neurology, you name it, federal, state, local. I mean, that's kind of why you need all hands on deck. So what my premise of this discussion is that we're trying to do these equivalencies. So Lumine, NTG is trying to find out, we want people with Down syndrome to get the biomarkers, we want them to get the treatment, we want them to get it, but are we prepared as a society, medically, socially, to even do this? So it's almost like a schism. There's some kind of dichotomy between what's done in research, trying to push it. So my point that I want to do in this particular meeting was more of a social side. How do we prepare people with Down syndrome about these issues? Because it's almost like this weird thing between you have Down syndrome, but we really don't want to say about Alzheimer's because it's not a happy thing. We don't want to talk about it. And all of a sudden they start showing sign of decline, many years later. And all of a sudden, what? I didn't know I was going to get Alzheimer's. I did. So it's this very unusual psychosocial dynamic. Doctors don't know. We're not prepared. So really the point of my angle on it was to try to connect to the social side of preparing ourselves and getting all of us, AD&D, NTG, all the organizations, every Global's here, all these organizations to prepare for what's coming and how we prepare and get ourselves ready. Marketing, messaging, discussion, education, training, updates, awareness, everything needs to be done. If all of a sudden the treatments are available, we're not ready. We got to be ready.
We certainly do. Seth, these are really exciting advances that are happening for dementia. And I know a lot of people out there are interested. One of the things I like to do, and I missed this the last time we chatted, but one of the things that I like to do is ask our guests to talk about, three things, three pieces of advice, three words of wisdom that you would offer to listeners related to health and wellness, health equity for people with intellectual and developmental disabilities. And I'm going to pivot on that just a little bit. Give us three things to be hopeful for, positive about, relating to all of these advances in treatment for dementia.
Well, definitely, I think the foot is on the pedal, the gas. I think there's definitely a lot of energy, and it's getting the word out there. So we're really, and it's a shame that you have to push the word out there. So there's interviews by Washington Post. We're having a lot of interviews and articles in Helen Magazine. So there's definitely the word is out there, and I think people are seeing the need in terms of the equity involved in it. So definitely, and I think the great part about not only getting the word out, but seeing that we as partners. I mean, it's almost like the way that when COVID happened. When COVID happened and we in the developmental world, all hands on deck, we needed to work together as a society and organization. We put out a webinar, we worked together. So to me, there's similarity where all of a sudden, not that we never really worked together, we did, but a lot of us, live in silos. You go back to your corner. So I really think this is really an opportunity just
to be a part of the conversation,
Absolutely.
To get information out about this.
Absolutely.
What other words of wisdom?
Well, the other part about it is basically it's still science. We still have to really go to the science and push the researchers in science. So part of it is getting the word out there, working all together. We still have to deal with the science.
So be patient. Yeah. So we've got to study
as hard as it may be.
Yeah, we're excited about these advances,
right.
But there's more research to be done to look at efficacy,
Absolutely.
safety, all of those things before we can just put it out there.
And we have to finally really prepare the people. We had to really get out there and talk to the moms and dads, people with Down syndrome, the societies, organizations, and we really have to be thinking through thoroughly on how to best deliver these messages of a condition. And one of the messages could be really a lot about health and wellness. So right now, what can be done in terms of helping reduce and mitigate maybe some of the signs and decline of cognitive dysfunction is just the way we live our lives.
Yep.
Sleep right.
Eat the right things.
Eat the right
Don't
thing.
eat the wrong things.
Okay.
Yeah.
You do exercise.
Mental health awareness.
Be happy. Be happy. Be happy. Right. Be happy.
Yeah.
Definitely. And if you have, say, high blood pressure or some health issue,
Those things.
So these things are not shocking, and especially in people with Down syndrome, high risk of obesity, sleep apnea, thyroid dysfunction. So there are inherent vision, hearing problems. So inherently within the Down syndrome population, there are inherent health complications. So therefore, if more work was aggressively put on, because sometimes there's a level of ambivalence about health and wellness. We put out fires all the time, crisis management.
We need to be more preventative.
We can do that.
Yep. Seth, thank you again for talking with me, for joining me on this podcast, and more importantly, for the work that you do and have done in this field. It's incredible, and I can't wait to talk to you another time to hear more about what's happening in this.
I'll give you the update next time.
All right.
More to learn.
Sounds great.
Very good.
Thanks
Thank
so
you.
much.
My pleasure.